Dear colleagues and friends, it's a pleasure to be back in Ukraine, a pleasure to be back in Odessa. Thank you very much. Thank you to the organizing committee, Paddy, Jerry, Tanya, all those who worked to prepare for this conference, for your invitation. Most of you, all of you, will know that in contrast to what has been happening globally, that is a 35 to 40% decrease in the number of new HIV infections and a 35% decrease in AIDS-related deaths since 2005 or 2010, the region, and that is shown on the right part of the slide, is the only region of the world that has seen a steady, fast growth in the HIV epidemic. And so what I would like to do this morning is try and identify a few specific or relatively specific features of the epidemic in the region, and I hope that that will be helpful to frame our discussions in the next 2 days on the Fast Track City program in the region, on how to focus and manage programs in Eastern Europe and Central Asia, but more generally, how to think about public health in times of transition in Eastern Europe. The first two points I'd like to make, and I think these are key points to our discussion, are first that this is a late epidemic as compared to the rest of the world, and an epidemic that has developed and continues to expand in middle and high-income countries in the era of antiretroviral treatment and effective prevention strategies. I would almost like to say an epidemic that has developed and continues to expand despite it happening in middle and high-income countries, and despite it happening in the era where the science tells us what it is we need to do and should do. The second is that this is a concentrated epidemic, as we call it in our technical language. That is, it's not a generalized epidemic of the type you may see in other parts of the world, such as sub-Saharan Africa. It is an epidemic that is mainly driven within subgroups of the populations, and historically this has started with people who inject drugs in the region, and a concentrated epidemic that confronts or that challenges also the cultural, societal, structural, and political challenges of what I'm calling here a still transitioning post-Soviet space. And I think we've heard some of this behind the words of the Mayor Trukhanov in his introductory remarks. Now, you've seen this first slide of a rapid growth of the epidemic. Here is a sort of photograph of where it is now. UN data 2016, we'll have 2017 data in a few weeks from now. 1.6 million people living with HIV, 190,000 new infections occurring in year 2016, which means an increase in the number of new infections in the region by 60% between 2010 and 2016, and an increase by almost 30% in AIDS-related deaths in that period. Now, the dynamics are not quite the same and have been changing in the last few years. I will be talking about problems, issues, and challenges. I also want to talk about progress. And what you see on this slide is that the elephant in the room, of course, is the Russian Federation, and that the number of new infections registered in the new Russian Federation is by far the largest in the region. It's actually 80 to 85% of new cases in the region. But what you will also see in the region is that in the Russian Federation, there's been a somewhere 30 or 35% increase in new infections between 2010 in blue and 2015 and 2017 in red and yellow, whereas in the other countries in the region, including in Ukraine, in the same period, there's been either a stabilization or a decrease in the number of new infections. In that same period, Ukraine has seen a 16% decrease in the number of registered new infections. This slide is to illustrate my point about the late epidemic. What you see in red is the increase in prevalence in the general population in the Russian Federation in between 1987, the first case identified, and 2016. And as you can see, this is a sharp exponential increase in prevalence, but the breaking point is really the mid and end 90s. And if you think that one is diagnosed with HIV somewhere 5 years, let's say, after infection, this means clearly that the epidemic has started in the region in the times of societal disarray, in a time where health systems were actually experiencing huge challenges in the region, that is in the 90s, in the 5 to 10 years that have followed the fall of the Soviet Union, at times where the entire region has also witnessed a huge epidemic of injecting drug use. This slide shows you the dynamics of the distribution of new diagnosed cases in the region by age, and another signal to me that we're dealing with an epidemic that indeed started somewhere in the 90s and early 2000s is the fact that most of the cases are in the age group of 30 to 39 or above. And this is a trend that is more and more visible. As you can see, in 2017, there was a huge peak of new cases in that age group throughout the region. The other observation is that, of course, any country is not a homogeneous country when it comes to HIV epidemics. I will not go into the detail of what's happening here in the various oblasts of the Russian Federation, but what you can clearly figure from this figure just by the colors is that, let's say, in the Irkutsk region, number 18, or in the Ekaterinburg region, the issue is much more acute than it would be in other parts of the Federation. And this, to me, points out to the need that each oblast and each municipality in a particular oblast have a heavy responsibility in where and how much they place HIV and TB in their overall way of looking at public health in their respective regions and cities. Now, I said it's a concentrated epidemic, and a concentrated epidemic is about particular key populations or subgroups of the populations. And I'd like to use here this particular definition of a key population. These are individuals and communities who have disproportionate burdens of HIV or TB risk and disease and lack access to essential HIV services. And across the world, this is gay men, bisexual men, and men having sex with men who have a 28 times higher risk of acquiring HIV than the general population, sex workers of all genders, people who inject drugs of all genders, transgender women, prisoners and detainees, and sometimes detainees are forgotten, HIV uninfected partners in discordant relationship, that is, a relationship when one partner is positive, the other is negative, and adolescents from all of these communities. Just to illustrate these points, these are data from St. Petersburg, and you can see the sort of figures, the very high prevalence figures, 48% HIV among people who inject drugs in St. Petersburg, 23% among MSM, 2.5% among sex workers. In Ekaterinburg, on the top line, 57% among people who inject drugs, 16.5% among MSM, 14% among sex workers. And throughout the region, one of the reasons why the epidemic continues to grow and develop in those communities is that not only is the society stigmatizing and discriminating against these people, but the legislative and the policy and the policing background is hugely unhelpful and opposing. Sex work is criminalized across the region, including here in Ukraine. Everyone has heard about the sex orientation laws and propaganda in the Russian Federation and many countries across the region. Same-sex relationship is criminalized still in a few countries. Drug possession for personal use is still criminalized in many countries in the region. And in countries where it is not criminalized, the threshold of drugs that would delineate between what one would call personal use and trade, sale, or trafficking is so low that actually the difference between decriminalization on paper and criminalization is extremely small. HIV transmission is still criminalized in all countries of the regions, and there still are a significant number of countries with restrictions on entry, stay, and residence of people living with HIV. There are countries with policies limiting the provision of harm reduction, and as you know, in the Russian Federation, Uzbekistan, and Turkmenistan, methadone, or what I would call agonist therapy, is illegal. And there are, in many countries, policies limiting the provision of HIV services for migrants, particularly undocumented migrants. And I'm very pleased that there will be sessions in this conference on this. We, in Western Europe, and even globally, I would say, often think of migration as what we see currently happening between the Middle East, Sub-Saharan Africa, and Western Europe. But we forget that this region, Eastern Europe and Central Asia, is one of the largest labor migration corridors in the world, with millions of people transiting from, let's say, Central Asia, Ukraine, Moldova, into the Russian Federation and other host countries. So as a result, the access to, let's say, harm reduction remains very small overall in the country. As you can see, in Central Asia and Eastern Europe, as compared to other countries, extremely small access to opioid substitution therapy. I would like us to call it agonist maintenance therapy, because this is treatment, this is not substitution. And access on the upper slide to needle syringes distributed is extremely low throughout the region. As a result, also, access to services for men having sex with men is extremely low. Here is a cascade showing that at the end it's somewhere only 3% or below 5% of MSM who access treatment and benefit from treatment with undetectable viral loads in the blood. This is a study in Moscow. The second set of sort of specific features of the epidemic is that the epidemic in Eastern Europe is occurring in a region where health systems have traditionally been very sectorial, very vertical, with very little integration, a country where care is often very specialized. The TB system wouldn't talk to the HIV or СПИД centers, and primary care is not talking to secondary or tertiary care. Also where physicians and healthcare personnel were not prepared to actually be dealing with the key populations that I have been mentioning. It's a region where the diagnosis is most often at late stages of infection, where testing strategies continue to be broad and not focusing on the key populations where most of the reservoir of undiagnosed infections are. It's a region where globally, access to antiretroviral treatment remains very low, 28% of the people in need accessing treatment, where prevention programs are usually underfunded, of insufficient scale and insufficient focus on key populations. And as I said earlier, harm reduction continues to be available to only a small fraction of people who inject drugs. And it's a country with a particularly high burden of tuberculosis and drug-resistant tuberculosis. Let me illustrate that briefly. This is a slide from the Russian Federation showing that basically 60% of the new infections diagnosed in 2016 were among people with less than 500 CD4 cells. That means with already an advanced stage of infection. This is a slide showing the Ukrainian so-called cascade of treatment. And you can see that the estimate in Ukraine is that 45% of people who are infected with HIV do not know their HIV status, that only 40% of people in care access to antiretroviral treatment, and at the end of the cascade, it's 23% of the estimated global number of people living with HIV in the country that have undetectable viral loads. And the figure is very similar across the region. To be fair, these are older slides than the one of Ukraine, and Russia has particularly progressed in the last 2 years with large increases in the number of people accessing to care. This is a region where 1 out of 8 new TB cases occurs in someone who is HIV infected. And what you see in the right is the rapid increase of HIV-TB co-infections throughout the region. This is a region that is a high-burden region for MDR-TB. So whenever you think of TB, you should think of multidrug-resistant tuberculosis. You can see Ukraine, 25% of new cases of TB are multidrug-resistant TB. And when it comes to people who come for retreatment of TB, it is 60% of new cases. And you can see how these figures throughout the region contrast to the very right with the global figure of 4 and 21 across the world. Talking about TB, one of the factors that is clearly contributing to the dissemination of TB in the region is incarceration. I'm taking this slide from work from Fred Oltis and colleagues in Ukraine that have shown that incarceration contributes to 6% of all cases of TB in Ukraine and 75% of TB cases among people using drugs because of the vicious circle of criminalization, incarceration, and then the high transmission of TB and those people then re-entering the community. And the same issues, I will not have time to go into the detail, are true for hepatitis B and C. 1 in 50 people in the region live with hepatitis C, and this is, when it comes to people who inject drugs, somewhere between 40 and 90% of people using drugs in the region being infected with hepatitis C. The third set of features is that the TB and AIDS responses remain underfunded, and that the challenges for the civil society organizations to work hand in hand with the public system, for the civil society organizations to be like an extended arm of the public health system, these challenges, although dealt with, although things change and move and progress, are still very high and particularly acute in times of transition in terms of funding from international to domestic funding. This slide shows you in orange and yet red throughout the years the underfunded, how the region is underfunding the AIDS response as compared to where it should be. The target is the upper right orange dot. That's the estimated need in the region. And on the same slide, you see the mortality throughout the region and the incidence rate throughout the region. And in the lower right part of the slide, where we would wish to see incidence and mortality be by 2020. And that's different from other regions of the world. I'm showing here Latin America and Asia and the Pacific to show regions with countries of similar mean economic status as countries of this region. Sorry. The countries in the region are particularly facing what we call the middle income challenge, that is the transition from donor, international donor, to domestic funding. This is still slow. It is far from bringing self-sustaining domestic budgets. There are risks of disruptions. This is largely due to the fact that the global fund is leaving the regions. And at the same time, medicines, for example, remain at very high prices in the region as compared with other parts of the world. And governments have what I call here limited willingness to pay for programs aimed at key populations and vulnerable groups. There is a remarkable non-governmental sector in the region, and many of my heroes of the civil society in the region are here in the room. However, most of these powerful civil society and community-based organizations in the regions have been dependent on international funding, and they face acute issues as now the global fund is leaving the region. And in some countries, there are now restrictions, for example, the foreign agent law or foreign grant registration processes to funding from international sources in the Russian Federation, in some of the Central Asian countries. And in most countries in the region, the basic contractual mechanism, the processes, the legal processes, so that the non-government sector could contractually engage with the public sector is still a matter of being worked out and is a very slow process to take place. And my last points are that if I look at it, I think the epidemic in the region is, because it is an epidemic, a late epidemic, happening in high and middle income countries, happening and developing at times when we know what actually we should do, is we should look at it as an epidemic of missed opportunities, and we should really think about regaining those opportunities. I am pleased to say that there is progress across the region, but we do need to take that progress further. Examples of progress: PrEP, now becoming available in Georgia, Moldova through the public sector, Ukraine through the Public Health Alliance. Belarus, Kazakhstan, Moldova, Ukraine have scaled up harm reduction programs, now with domestic, or at least partly domestic resources, although I understand in Ukraine that's not an easy process. There's been investments, specific investments by local authorities. And here I take the example of the city of St. Petersburg that has really put in serious money and funding NGOs to do prevention work. And in many countries in the region, including Ukraine, Kazakhstan, Moldova, some countries in the Balkans, there's been agreements, let's say, between the country and the United Nations system to procure drugs at much less high prices. Kazakhstan, for example, on the same budget, is now capable of buying twice as many drugs as before. One of the successes and examples of progress, I think, to me in Ukraine, is the significant decrease in the number of new cases among people injecting drugs throughout the years, here 2005, 2017, and that despite a very low number, actually, if you think of it, of people on opioid substitute therapy as compared to the number of people estimated to be injected drugs and the number of people actually reached by the Alliances program, which means that meeting people, talking people, condom distribution, information is key also in our harm reduction strategies. This is showing how in blue the number of new infections are decreasing in St. Petersburg, and that figure crosses the global increase, or the increase at federal level if Russian Federation is taken as a whole. And this is a slide taken from a mathematical model of what could actually happen if these programs were scaled up. As you can see here, if 90% people were on antiretroviral treatment and 90% people at risk would be reached by prevention activities by 2020, this would mean a decrease by 500,000 in 2020 in the number of new infections. If, let's say, in orange, 50% of people living with HIV access to antiretroviral treatment, and currently it's 30%. So it's not impossible. There would be 125,000 new infections averted in the region. So to end, let me just say two things that seem to me particularly important to the region. One is the people. I have tremendous respect and tremendous faith in what the people of this region can achieve. I've met just shining personalities and people and communities across the region. Here is a picture of an NGO working in harm reduction and needle exchange programs with people who inject drugs in Donetsk under hugely difficult environment. And here is a young woman I met in St. Petersburg who started a program where she takes back non-utilized medicines from people who are changing regimens, or unfortunately from people who die, and then stocks this pharmacy and sends it by mail, by surface mail, to people who would call her because there is a disruption in their treatment where they live. And the second is that health is very much political in the bad sense of the term and in the good sense of the term. In the bad sense of the term, it is that those drug policies that I've mentioned that are based on prohibition law enforcement, that are based on the concept of prohibition, and then the concept of law enforcing prohibition, hamper access to health programs. Methadone remains illegal in the Russian Federations. There continues to be high rates of incarceration for minor drug offenses across the region. 55% of the people in jail in the Russian Federation are there for minor drug offenses. There is still a very low proportion of national HIV budgets devoted to prevention and to vulnerable groups, and this is a political decision. Anti-LGBT legislation continues to be proposed or introduced across the region. And of course, the fact that a country takes the decision to discontinue a life-saving treatment like methadone in Crimea and then in the separatist areas of southeast Ukraine is a key political decision. And what I'm seeing more globally is that global health is more and more challenged by political issues. It's more and more a political discussion in New York at the United Nations when it comes to global health agendas. Across the world, and not only in this region, do we see the clash, what I call here the clash of norms and ideologies, that is, decisions based on ideology, perception, feelings, rather than on what the science tells us to say. And that, of course, is not helped by the rise of nationalism in the face of somehow more and more interdependent world, and at the time when multilateralism is actually losing ground. And in the new global of change in global health that we will be discussing across the days in this conference with urbanizations, new patterns of in-country rather than in-between countries inequities, new economic powers, new multipolar geopolitics, health and health becoming more and more a commercial issue rather than a public health issue, and at times when there's more and more individualism as a paradox, when we're more and more interconnected. So at the end, it's all about choices. And I think that's really the function of politics. And I would like to end to this. Health is a political choice at all levels of governance, municipal, regional, country, and global. Thank you for your attention.